Hello, everyone, and welcome back. Before we dive in, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. All right, so today we are jumping into part 49 of our masterclass. Last time in part 48, we wrapped up MDC 10 and 11, covering the endocrine and kidney systems. Today, we're taking a fascinating journey to demystify one of the most critical translations in the entire medical world. We're talking about how complex clinical documentation gets transformed into hospital classification and ultimately reimbursement. We are going to completely decode the clinical equation behind DRGs and ICD-10 PCS. We'll be breaking down the exact formulas that drive inpatient revenue, focusing on how this applies across the board, including our specific focus today on MDC 12 and 13 for the male and female reproductive systems. Let's get into it. So let's start right at the foundation. A diagnosis-related group, or DRG. What actually is it? Well, it's essentially a statistical classification system used by Medicare and other major payers. Think of it as the ultimate clinical formula. Clinical similarity plus resource similarity equals one payment group. It's that simple. Every single time a patient is admitted, their entire stay, all the resources they used, all the specialized care provided, has to be categorized into one of these specific buckets. And that bucket determines exactly how the hospital gets reimbursed under the inpatient prospective payment system. Here is our roadmap for today's explainer. We're going to cover MSDRG architecture basics, severity and CC/MCC logic, sequencing the principal diagnosis, ICD-10 PCS procedure coding, and finally, obstetrics versus medical and surgical cases. Okay, moving right along to Section 1, MSDRG architecture basics. There are 5 essential ingredients that feed into this massive logic engine known as the MSDRG grouper. The principal diagnosis, that is your main driver. This initial code basically sorts the patient into one of 25 major diagnostic categories, or MDCs, based on the organ system or etiology. For instance, whether a patient groups into MDC 12 for male reproductive system disorders or MDC 13 for non-obstructive female reproductive disorders, it all begins with accurately capturing that single principal diagnosis. From there, we also input secondary diagnoses, procedures, and patient demographics. Things like age and discharge status. It's like a giant recipe where every ingredient totally matters. Now, once a patient is placed into a major diagnostic category, we hit a really critical fork in the road. The system automatically partitions cases into 2 completely different groups, medical or surgical. And the rule here is incredibly strict. If a procedure is present that meets the CMS definition of a major operating room procedure, boom, the case is routed straight to the surgical partition. If there's no major OR procedure, it stays right there in the medical partition. Which brings us to Section 2, Severity and CC/MCC logic. This is where things get really interesting. We have to account for how sick the patient actually is, right? These severity adjustments are the absolute core of the MSDRG system. Basically, secondary diagnoses act as massive multipliers. A CC, which stands for complication and comorbidity, adds moderate severity. Think along the lines of a UTI or malnutrition. But an MCC, a major CC, that indicates high severity and huge resource use. Conditions like sepsis, acute renal failure, or respiratory failure act as powerful drivers that significantly bump up the relative weight and reimbursement of the case. Conversely, if a patient just has simple pneumonia with absolutely no additional complications, they just fall into the baseline no CC/MCC tier. And you can really see how this plays out in what we call the triplet structure. It visually separates a single base condition into totally different tiers. Take a base DRG for heart failure, for example. You don't just have one generic heart failure payment group. It branches out into 3 vastly different payment tiers based purely on the presence of those CCs and MCCs we just talked about. This brilliantly highlights why capturing every single secondary diagnosis is just absolutely crucial for accurate reimbursement. All right, Section 3, Sequencing the Principal Diagnosis. Let's talk about some detective work. We have to look at the difference between the rules and the reality in a hospital record. Vague documentation is a massive problem. Imagine a physician just writing chest pain in a discharge summary when the patient actually had a full-blown heart attack. That leads to incorrect, lower-weighted DRG assignment and some serious compliance risks. But on the flip side, good documentation says acute anterior wall MI. That specific clinical linkage is incredibly powerful for accurate grouping. It really shows why clinical documentation improvement, or CDI teams, have to issue queries when the documentation is even slightly ambiguous. And speaking of ambiguity, sepsis is one of the highest impact conditions in healthcare. Which brings us to a really critical CDI question for you to ponder. Is the sepsis the principal diagnosis, or is it a complication of another infection? The ability to accurately sequence conditions like sepsis literally determines the entire trajectory of the MSDRG. So, how do we solve it? By following a strict 3-step sequencing rule. Step 1, identify the underlying systemic infection, like an E. coli UTI. Step 2, identify if there is organ dysfunction. If there is, that elevates it to severe sepsis. Step 3, sequence the underlying infection code first as the principal diagnosis, followed by the secondary severe sepsis code. And a quick tip here. Terms like bacteremia or urosepsis are massive red flags for CDI teams. Bacteremia just means bacteria in the blood. It doesn't necessarily mean systemic sepsis. When coders see these vague terms, it requires an immediate physician query for clarification. You cannot just guess. Let's shift gears now. Section 4, ICD-10 PCS procedure coding. Over on the procedural side, ICD-10 PCS is highly structured. It is essentially a 7-character puzzle, and absolutely every single position must be accurately populated straight from the operative report. Character 1 is the section, character 2 is the body system, 3 is the root operation, 4 is the body part, 5 is the approach, 6 is the device, and 7 is the qualifier. Get one of these wrong, and the whole code falls apart. Let's look really closely at character 3, the root operation. Here is a vital difference you absolutely must master. Excision versus resection. Excision means cutting out just a portion of a body part, like a partial nephrectomy or a breast lumpectomy. Resection, on the other hand, means cutting out the entire body part without replacement, such as a total nephrectomy or a total prostatectomy in our MDC 12 patients. Terms that sound kind of similar clinically are coded very differently in PCS. And root operations define the true objective of the surgery. An appendectomy, that maps to the root operation excision or resection, depending on if they took the whole appendix. But a CABG, a coronary artery bypass graft, that maps to the root operation bypassed because the objective isn't taking something out, it's altering the route of a body part. It's all about the objective. Then we have character 5, which is the approach, literally how the physician reaches the surgical site. An open approach means cutting straight through the skin or mucous membrane. Percutaneous is entry by a puncture or minor incision. But add a scope to look around, and it becomes percutaneous endoscopic. Let me tell you, getting this character wrong will instantly derail your MSDRG assignment, which is exactly why coders have to verify the approach directly from the operative report, not just the title of the surgery. Which brings us to our final variable today. Section 5, obstetrics versus medical/surgical. Take a second and think about this one. When a pregnant woman is admitted to the hospital, how does her coding differ? Well, pregnancy dictates a completely different set of rules for the procedure coder compared to a standard medical or surgical case. It is a whole new ballgame. In the PCS system, the obstetrics section follows unique rules. You only use one body system value, character 0, which stands for pregnancy. And this applies all the way from conception to delivery. Furthermore, the procedures are often performed not on the mother's organs, but on the fetus or the amniotic fluid. In the coding world, that is defined as the body part products of conception. This specific section utilizes 12 specific root operations, totally unique to this state, including terms like abortion and delivery. And here is a fantastic example of that exactness in action. Even the birth process hinges on very specific details. A standard, completely unassisted birth is coded with the root operation delivery. But the very second a physician uses forceps or a vacuum or any other assisting mechanism, the code completely changes. It technically becomes the root operation extraction. Ultimately, all of this complexity brings us back to the golden rule of inpatient documentation. Every patient's record should comprehensively describe their clinical journey from admission to discharge. The reimbursement data, the hospital profiling, the DRG assignment, they are only as good and only as accurate as the clinical story that the documentation tells.
So I want to leave you with this provocative thought to challenge you in your daily CDI and revenue cycle investigations. If a single missing word, like failing to write severe before sepsis or writing excision instead of resection, can drastically alter a hospital's payment and fundamentally misrepresent a patient's severity profile, how will you bridge that gap between clinical reality and coding rules today? That wraps up part 49. Next time, in part 50, we will be diving into MDC 14 and 15, looking at pregnancy, childbirth, puerperium, and neonatal DRGs. You won't want to miss it. Finally, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. See you next time.